This
Who have
conference
already
will now be
prepared
recorded.
and they are appearing in this February exam. Um, though everyone can, have some benefits from the points I'll tell. Um, Today we will talk about the two very important modules of MRCOG on which the whole exam depends, um, and it decides like how safe you are a doctor and how beautifully you can handle the station by handling your patient and also by handling your colleague in structural discussions. So let's start. In the patient safety, um, this module is applicable in whole of the station. We all know that there are three different kind of stations. One is structural discussion, then there is a patient simulated task, then there are teaching stations. So teaching stations are also kind of interaction with the colleague, and structural discussion is also interaction with your consultant, or if there is labor ward, so there will be labor ward coordinator, there can be, or I mean you have to read carefully to whom you are giving the viva. Yeah, because sometime it's labor ward coordinator, sometime it's consultant, so accordingly you have to ask the questions. So, and in SPTs, there are another two types. Like one is role player and clinical examiner stations. Like only two people will be there, and uh, you will be the candidate to be tested for their skills. And then there will be role player, clinical examiner, and lay examiner. So those stations are the most mark scoring stations. Um, Here, even if you in lay examiner station, the benefit is if the station is coming out of your like you have not heard about it or you haven't read about that station at all, but if you are handled to communicate well with the patient and you include all the patient safety points, and lay examiner pass you for your skills of communication, and even your applied clinical knowledge doesn't fit to the best, and clinical examiner doesn't like your way and he fails you, still you can pass this station based upon lay examiner's marks. But if lay examiner fails you, then it is difficult for you, you cannot pass that exam in that situation. So those stations which are having lay examiners, they are the most marks scoring stations, and we usually don't know like in which station will that be two examiner or three I mean one examiner. So it's better to prepare yourself completely in maximum in the communication with patient and family skills, and along with that all the safety points we should be knowing. So here I have divided it into stepwise, like where and how you can uh, involve the patient safety points. Some points are in information gathering, some points are in examination, some points are in applied clinical knowledge. And see, if there are 8 points, suppose in their list, marking list, there are 8 points, and you include 6 to 7 points in your list, in your station, you will pass. But if that will be 3 to 4 points only, you will not pass. If you will be having 5 to 6 points, you will have borderline pass. So it is better to have a gross knowledge of all the safety points, and better to practice it every day in all of your stations. Yeah. So in information gatherings, in gathering we take history, we targeted history depending upon the station, and examination and investigation. This all we what points we have to include in that. So allergies, okay. Latex allergy, we have to ask everyone. Drug allergy, latex allergy in all preoperative patients, and drug allergy, food and metal. if contraception station is there, you have to ask metal allergy. If you are offering copper tea and she is allergic to zinc, so that can, because most zinc allergy is the commonest in metal allergy. So you can discuss it, and copper tea insertion can be we can do any alternative method of contraception, we can counsel about to the woman. So that's how allergies are important. If she is penicillin allergic, you have to tell any alternative antibiotic to her. But in penicillin allergy, it is written in the guideline that you have to send the patient to the mic to the like you have to assess it completely, what kind of reaction it was. Was it like just fever, flu, or mild reaction? Then we can still give it, especially in syphilis cases. And then if it is, you see, a severe enough allergic reaction, then desensitization is to be offered, and like patient is to be further assessed. So these are the, I mean, allergies you cannot miss in any case. In all the stations you will talk about allergies. Even if you are giving structural discussion, you will tell the consultant that I'll rule out the allergies. And in teaching station you will teach the candidate, and you will tell the candidate or the student that we need to rule out all the allergies. So allergies give they always have an asterisk point, and you will be given mark for it. Then coming on to the Jehovah Witness, like it is kind of respecting their beliefs and culture, so that you are not going against their wish. I mean, you can't go against their cultural belief and wishes. So that's why you are asking about Jehovah Witness. And what I suggest, that to know about blood transfusion reservation in all the station, whether it's relevant or it's not relevant, because you will never get to know that that you have missed this, and you can't afford to miss this Jehovah Witness in any station. In one or two station, you it seems that it's irrelevant, like in contraception station it's irrelevant, then you can think about it and skip it. Okay. But in other stations, make it a habit of asking to everyone, like any pregnant woman, any gynae woman, so that that you don't miss the blood transfusion history. Then the blood group, you can ask, because most of the women in UK they know it, and if you write it, that's good. Folic acid, though it doesn't come exactly in the patient safety blood group, because it's not a compulsory thing to know. Then folic acid, they love it the most, we know it. And the high dose folic acid, when you have to give high dose, okay. In obesity guidelines it's more than 35 when we give 5 milligrams. Then sickle cell anemia, throughout we have to give 5 milligram folic acid. In thalassemia, neural tube defects, okay, personal history or family history of neural tube defects, you have to give 5 milligram folic acid. And apart from that, in the station, you need to identify high risk. Like if you are unable to identify that it is a high risk pregnancy, then you are not a safe doctor. Any hidden agenda is there. Like if suppose a patient has come and she's saying that, midwife has sent me to you, I don't know why. Then you must think that, okay, something can be there which I need to dig out. So then you have to take a proper history, keeping in mind the hidden agendas, any domestic violence, any female genital mutilation, any sexual abuse, any assault. So all these things you have to keep in mind and identify it. Then contraception, you have to check the contraception in planned pregnancy or unplanned pregnancy. Don't miss contraception, and offer a counseling for contraception after the pregnancy or after the delivery. Okay, so you can tell the patient that, after your delivery we can talk about it, and I can refer you to the concerned people or the clinic. And then we have to, okay, coming on to the next slide. Then offer confidentiality. Suppose there is a teenager girl and you do not offer confidentiality, she'll not say anything, she'll be afraid of you. So confidentiality is actually a patient's safety, because when she will feel secure, confident, then only she will express, or she will give you the history, and you can get to know, or diagnose what is the problem, or you she will tell you, give you the history, and you will make the diagnosis. So confidentiality, always ensure confidentiality wherever it is required, in teenage pregnancy, in FGM cases, and in assault cases, in domestic violence. First thing to do is ensure confidentiality to the woman. And but in in teenage pregnancy, how you will handle it, i I assure you that whatever we are going to talk here will remain between you and me, until and unless your safety is at risk. Okay? So if you're, because you have to tell the girl that if your safety is at risk, we cannot keep confidentiality in that situation in a minor girl. Okay? We have to involve safeguarding team, we may involve police also, but you have to, but confidentiality word you have to speak, and clause also you have to put wherever applicable. In FGM also, you can say whatever we will discuss will remain between you and me, until unless yours or anybody else's safety is at risk. Your safety, actually, if she is, she's adult, you can't do anything for her. But yes, if there is anybody else, any other minor girl in a family, if she's at risk, then you have to involve the safeguarding team or maybe police. Then you should have knowledge of Fraser and Gillick competencies, because there is a station in the part 3 that if a teenage girl's mother comes, then, or father comes, they are angry parents and they want you to uh, reply back to their questions, like why you offered contraception to their teenage daughter, or why did you offer MTP, or so you have to explain them the law in UK. So you should have a knowledge of Fraser and Gillick competence, and you should put this in your station also. Like if in any minor girl, teenager girl, you have to tell her that, okay, after taking all the history examination, you have to tell her that, ask her few questions, and that, and then tell her to first give her the knowledge, like, we can offer you, there are two three options that can be offered to you, like, medical termination, or we can, offer you operation. So tell her that medicine will be, we will give you by mouth, and some tablets will give you to put inside through down below area. In operation, the good thing will be that it will be in one day, and but you will be put to sleep, but then the risk of operations will be there. Then you ask her to repeat, so can you tell me, like, mm, what options can be there for you? I mean, what do you understand by our conversation? Okay, yes. And can you tell me, like, well, what kind of a risk you are understanding from our conversation that can happen from this option which you have opted? Okay, so, and then, examiner will understand that you are checking her for Gaelic competence or Fraser guidelines you are following. So you have to put it in your clinical stations, then in your structural discussion, or in angry patient discussion, you can tell the woman or tell the mother that, uh, we work according to law in UK, and here the things are, Fraser guidelines are there, in which, we check the understanding of the child or the teenager, and if we found that they are understanding, they're like they are competent enough to understand the benefit and risk of the procedures, or for the medicines we are offering them, then we go ahead, like, we are supposed to give them treatment. Okay, then we are bound to give them treatment, because if we are not giving them treatment, then there are more harms than benefit to the children or to the child. So, but you will never lose the, or you you will never tell the identity, or break the confidentiality for the patient to any relative. If the patient's consent is not there, then you will not tell anything about the patient to the relatives. So that also come under Data Protection Act and confidentiality. So you have to take care of that. Em- they can pull you to the corner, that you have to tell me whether these are your signatures, you have written this prescription, how unsafe person you are, you should have involved us. Then also you will not tell that this is, if they ask, okay, tell me, is this your signature, just tell them, yeah, these are my signatures, but whatever is there, I'm not going to tell you that you know what I have given, or I have written, or why I have written this, because this is we are bound to the Data Protection Act in UK, and we cannot leak our patients information to anyone if they have not given us permission. So I'm sorry, apologies, I can't discuss anything about my patient. And whatever grudges you have, there are proper channels, you can go through that. So let's discuss about those channels, and let us not talk about the patient when, or the child, or the teenager, or the girl, when she's not around. So like this, you have to disperse at all. You don't have to disclose the datas, or information. So then there are another cases like Alzheimer cases, where daughter or son comes. Then they say that, how will you proceed? In that, you have to assess the mental capacity of the woman. So you'll say that, so you should have the knowledge of Mental Capacity Act also. So in this, you have to tell the daughter or the son that we need to assess the mental capacity of your mother. And after that, we will decide that what we can do, whether she is in a state of deciding for herself. If she'll not be able to decide for herself, then is there any will which she has signed, or has she given authority to anyone who can take decisions on her behalf? If not, then a best interest meeting will be conducted. So this mental capacity word is also a patient safety point, very important patient safety point. That also you have to note, that if such kind of scenarios comes, then you have to put the Mental Capacity Act. According to the Mental Capacity Act in UK, we are supposed to assess her. Then we can discuss the plan of treatment uh, with her. And if she'll not found that she's not capable of taking decisions on her own, then we can go to next of kin, or whoever she has given authority to. And if next of kin is not available, then we can have a best interest meeting. So I'm sorry, are you the next of kin? So if they are not, then you're not supposed to tell or give information about your patient to her daughter and son without assessing her mental capacity. Okay. And but now what will you do in the next of station for 10 minutes? You're not going to say this and keep silence. So if they say, no, but please tell us, how can we go about it? Okay, I can broadly discuss with you, like, if this kind of situation comes, what can we do? Yeah. So if she is endometrial hyperplasia patient, then not addressing to that woman, you can tell the children who have come to ask about their mother, that if this kind of situation come at this age and stage, usually we offer a camera test to see whether there is any associated cancer. And if we found some lesion in it, then we take a biopsy directly from that, or we offer further test imagings, or and then we, if everything comes out to be fine, normal, then we can put a coil inside, or we can give some oral tablets. um, but as your mother is having Alzheimer's, coil will be better option. Or apart from that, if there is any sinister changes, or there is a cancer, if it is a cancer, then we offer some big surgeries, which team of doctor decides about it. And there are many doctors, so like that you have to deal with the situation. Okay. Then VT risk assessment. VT risk assessment in every patient, obstetrics, you cannot miss VT risk assessment starting from early pregnancy till delivery. Every woman you will assess VT um, antenatally in during labor, after the delivery. We will reassess you. According to that, we may offer you blood thinners, or we may offer you stockings, or we may, we will encourage you to be as mobile as possible. So these are the lines you have to speak in the VT risk assessment. But that's the, that's a very very important VT, like patient safety point. Coming on to the next thing, targeted risk associated appropriate history is to be taken. That's again a patient safety. What does that mean? If a woman is having thyroid disorder, or suppose she's having Graves' disease, what are you going to ask her in the history? You, in Graves' disease, you will be checking her for the tremors, for, if she's having any protruding eyes, or any palpitation or racing heart. So this kind of history about the disease control is targeted history. Okay, so that kind of targeted history is very very important. And then coming on to the lichen sclerosis, exclude other autoimmune disease. Now, if a patient is having lichen sclerosis, then you have to exclude any thyroid problem you have, any skin, other skin problem in the family, and then pernicious anemia. You can ask her, because that is a relevant thing, and it is a patient safety point to take the relevant disease associated history and whatever can be related to that disease. Yeah. So if a woman is having lichen sclerosis, in the medical history you can take history of thyroid disorder, any other autoimmune problem you have, any pernicious anemia, because anemia can further, pernicious anemia being an autoimmune can be associated with LS and can aggravate LS and can affect the treatment and relapses of LS. So those kind of histories which are important, like, which are related to the disease. So those history points are to be included in every station to make your station complete. Okay. And then coming to the this thing, cancer stations, you have to rule out family history of cancers, any genetic testing if she has undergone, right? So that if she has not undergone the genetic testing, or suppose the genetic testing shows that uh, um, she is BRCA1, BRCA2 positive, then you can offer the treatment accordingly. Oophorectomy you can offer her after family completion, salpingo-oophorectomy. And to her daughters, ask about her daughters. Take the family history, take the obstetric history. How many children do you have? How many daughters do you have? Because I remember I had a station, and the mother was, she was having ovarian cancer. Her aunt, her, mom, they were having breast and ovarian cancer. Then I advised her, because it's running in your family. How many daughters do you have? Okay, so we can offer testing to them as well, and to you as well. Then she said, okay. So that contains a, patient safety points, that you are aware that, it is having a genetic impact and we can offer it. So family history of cancers are very important. In infertility, you take history, include all the patient safety points, but ask for the support for upcoming baby, you know because they are very particular about it, that anyone who is planning for children, or then they should have enough support for the child. So ask about support for the upcoming baby particularly, that will give you a safety mark. And then in labor and delivery stations, ask about how far she stays from the hospital, and is there enough transport facilities for you to reach. I mean, how many minutes you take from reaching from hospital to home. And do you have enough telephonic facilities available? so that if she is having any emergency, she can she can communicate quickly. So you have to decide, like if you are giving methotrexate to ectopic, you advise her to stay in the hospital, and if she's nearby, then only you will discharge her. Otherwise, you will advise her to stay. If she is having any pain or any complaint, tell her to stay with you, so that because it will be difficult to communicate easily, and that can lead to any problem, any internal hemorrhage, internal bleeding can be there. Similarly, if she is having placenta accreta or previa, you can ask about the like how far she is. Any high risk patient, how far she stays from the hospital. So that will be a safety point. Okay. Then domestic violence, mental health, these are the general history templates. And you now, in the talks, it is written that you have to assess every pregnant woman for the domestic violence, and in nice also. So ask every woman about the domestic violence. Do you feel safe at home? Or is there anything which bothers you at home? Like, are you scared of something? Like, depending upon the situation, okay, there is no set dialogue or wordings which can, which we can use. And mental health, yeah, Woolies questions, down, depressed, and uninterested. So, do you feel down, depressed, or uninterested in your surroundings in recent few weeks, or ever you had any mental health problem? Okay, so these all are the safety points in the information gathering. Then never undermine your colleagues. That's a patient safety. Okay, because how it is a patient safety? If you will undermine your colleague, you are shaking the trust of the patient on the doctor, and that can lead to many allegations and burden on NHS. So they are very particular about it, that you are not going to undermine your colleagues at all. You have to handle the patient accordingly. And in this, um, see, um, if GP has said something to your patient which is not correct, suppose, okay, so you can't say that no, that's the last option, or that's not an option. We cannot consider it. You have just not tried tranexamic acid and you are talking about hysterectomy. That's a bad option. We can't say that. We will always be respectful to our colleagues, and will always, you will say that okay, yeah, that's a very good option. Okay, yeah, yeah. It is, it's the removal of your womb, and it is a big surgery or big operation which demands your stay in hospital for quite some time. And but there are many other options available nowadays. So would you like to hear about that? Then they'll say, so why doesn't why don't GP offer us that, and doesn't he know that there are other options as well? Then you can very quickly say, that's why he has referred you here. We are here to help you for this purpose only. Yeah. And whatever they say, you have to keep it on a lower profile, and just do not give it so much importance. At the same time, handle it with very much care, that you cannot you don't have to give it so much importance, and you don't have to ignore also. So make a path in between, because sometimes stations are only assessing you for these things, assessing you for your handling skills, for your communication skills. And if you ignore anything which has been said by the patient, you will lose the station, because they are being trained in that way, that whatever they are saying is the station. Okay, they will guide you for the station, like how you have to proceed. So it is always a good idea to keep on asking and checking the understanding of the patient. So whatever they have to say, they will say you in between. Yeah. And then never ignore any question. Do the safety netting in all cases. So that's again a history taking part also, that you have to check for bleeding, any discharge in obstetric patients, or any leaking. If you had any pains you have in term patient, then you in the end you have to give the contact number, written information, and communicate with her community care. So take care of the patient and everything else will follow. Opening with safety and closing with safety. Like you open your station by being a safe doctor, close by being a safe doctor by communicating in the end with her community care, because that is the most vital point in NHS. In examination, take care of the dignity of the patient. That's the patient safety. Involve chaperone in the examination always. That's the patient safety. If you are talking about investigations, check the identity of the patient first. So that's the patient safety. In applied clinical knowledge, if there is any emergency station, you have to say, I will call for help. If you do not say this from your mouth in the station, you are not a safe doctor. If you call for help, 1 point it will give you for your patient safety, 1 point it will give you for your communication with colleagues. So 2 points you will get in two domains by saying this one simple line. So always in your next upcoming exam, in labor ward, if there is PPH station, maternal collapse station, APH station, just say I'll call for help. I can't deal with it alone. Know your limits. If there is one consultant with you and there are two cases, one you will handle, one you will call your consultant, but you cannot handle two emergencies by yourself, and where a senior input is required. If suppose your consultant is also busy and there is another case, don't hesitate to call another consultant. There must be some other consultant also, second on call or from another unit. Take help from another unit's consultant, or who is not on call. What's the harm in it? Like we do it in our practice also. Like if our consultant is not available or we have two three cases simultaneously, so one case will be done by me, another one by my consultant on call. If third case is also there, we call our, sometime we call our HOD also, head of the unit or head of the department. So similarly they do in NHS, that they call the senior people or other people, but safety should not be compromised at all. Okay, so, because sometimes they say that um, okay, in labor ward you may feel this, if you may face this scenario, that okay, first consultant is, you have called the consultant in one station, another station you have done by yourself. Then when you are proceeding to the another thing, the labor ward coordinator will tell you that now this patient is having cord prolapse. What will you do? Or not cord prolapse, breach in labor, she's due for her delivery, vaginal delivery, and she's fully dilated. Then you'll say okay, we'll call the next on-call consultant, and somebody should be there in the hospital, so let us call the consultant, another consultant. So that will make you a safe doctor. You will pass that station, and these are very very important points, that you should be very freely going for the exam, and you should be behaving like, you should behave like a full-fledged clinician, and all of you are clinician doing well in your country. So it's better that you behave also like the same, and don't hesitate, don't get scared. It's like it's not that a big deal. Okay, you just have to interact as you interact with your patients, and you have to talk as you talk with your consultants. Okay, so just show them your knowledge, be very very systematic, and don't get scared of any question. Let it come and reply whatever you know. You know everything by now, so just reply in your own way, how you feel about it. Okay. So next point in applied clinical knowledge about patient safety is like checking bed for baby in NICU. If a preterm delivery cases come, first thing you're going to do is NICU bed. Suppose if there is no bed in NICU, you will do intrauterine transfer if she's not having any bleeding or not in advanced labor. Okay, if she's in early labor, preterm labor, there is no bed, you do intrauterine transfer. If she is fully dilated, or she's 6 7 centimeter, you can't transfer a patient who is in active labor basically, or she is having APH, you can't transfer. So you will be uttering the word from your mouth about the extrauterine transfer. I will discuss it with my consultant because the patient will need extrauterine transfer. So we will arrange for that in liaison with the neonatologist team. Then if you're performing any intrauterine procedure, any hysterectomy or DNC or hysteroscopy we are going to offer her, first thing we need to do is excluding pregnancy, as we do in our own practice. Yeah. So UPT is to be done, urine pregnancy test you will be offering the woman. Then in pre-op patient, WHO safety checklist is a big safety point. Consent, very important safety point. It is a safety for us. Consent is it's a informed consent. Patient has signed the consent. If you are taking a um, cesarean section, you need to inform the numbers, and you need to take the consent, and somebody, ST2, ST3, they should take the consent, not the midwife. Midwives are not taking the consents for you. Doctors are supposed to take the consent. Then in any cancer stations, 2 week pathway, if you'll not speak, you'll not gain marks. Yeah. So if there is a sin 2, sin 3, you will say that, we'll put you in a 2 week pathway. Colposcopy will be done. Your report will come. And it, if that will be showing cancer, you'll be in 2 week pathway, and you will be offered treatment after your diagnosis has been established. Okay. So 2 week pathway, you have to speak, you have to tell to the patient. Okay. And if suppose a woman who is on steroids, and we know that if she is on more than 7.5 milligram prednisolone for more than 2 months in the pregnancy, or around the labor, so you will be offering her the stress dose of steroid, that's the hydrocortisone dose. So if you are not saying this, you're not a safe doctor. You have to offer a stress dose of steroid in labor, and for 12 to 24 hours, and then assessing the mobility and handling tools in obesity. In morbid obesity, you will do the risk assessment for moving the patient, and handling instruments like mm, uh, blood pressure cuff, or OT instruments, or OT table, uh, shifting trolleys. We have to check that. So you will be telling the patient that we'll do your assessment for mobility and handling tools at 36 to 37 weeks. And in structural discussion also you have to speak this word. Okay. Because suppose if patient comes in labor, and there are no trolleys for you to shift her, or your OT tables are not accommodating her, that will be very shameful also, and very difficult also in the midnight. If patient comes, then it will be difficult to manage. So these things makes you perfectly safe doctor. Drug use, safe use. If she is breastfeeding, is it a safe drug? If it is a safe drug, you will tell the patient that it's a safe drug. Like if she is on lithium, you will tell her, we will not be able to offer you this drug if you will be breastfeeding your baby. So at that time, we'll stop it and switch it over with a safer medicine. Or if but in consultation with your, mental health specialist. But if they will say that we cannot switch it over, then there are formula feeds, and baby can have that. So we will be talking about this when the time will come. Will that be fine? Okay. So that shows that that lithium cannot be offered in breastfeeding. And if she's on lithium, you have to tell her that we will be checking the levels of the lithium throughout 4 weekly till this much weeks, and then weekly till labor. And we will be, withholding it during the labor. So when you speak these words, these things will make you a safe doctor, and you have to give complete information to the patient. For that, you should have enough information within yourself, that you should have read all these things. And now it's time that you just flip over the pages of your notes, and cover as many stations as possible in these last 3 4 days. And the day before exam, just you can stop doing it, everything, reading everything. So similarly, if there is a disease station, you will tell in structural discussion or in SPT, whatever comes, you have to tell that nephrotoxic drugs are to be avoided in this patient. Any drug which is not safe for her is to be avoided in this patient. If she is on hypertensive medicines and she's pregnant, she come for pre-pregnancy counseling, or then you or early pregnancy, you will tell her that we need to switch it over with the safer medicine in pregnancy, though these are very good drugs outside the pregnancy, but as you are pregnant now, let's switch it over and let's talk to your specialist and we can have safe medicines. So like this, you have to handle the station. um, when to stop, when to start again, all of this information should, you have to provide it, because these have patient safety points. And if you miss these things, you lose your patient safety points. Those are the, they weigh too much. And if you are giving any woman, if ectopic pregnancy is there, you are offering her methotrexate as medical management, and she takes alcohol, you have taken history, and you've asked, do you take alcohol? Yeah, I do take. Okay, we can put you on a methotrexate drug, there are options, would you like to get that? Yeah. Okay. And if you don't say that, don't take alcohol at this time, how would you be supposed to how we can suppose that you are a safe doctor? So you have to ask her to stop alcohol when taking methotrexate. If she is on metronidazole for trichomoniasis or for bacterial vaginosis, you're giving her metronidazole. Exclude the drug allergy, and um, just a sec, drug allergies. And if she's not allergic to metronidazole, give metronidazole, but tell her to stop alcohol while on the medicine. Okay, to stop this reactions, because there can be bad reactions with the medicine, so we advise you to stop it. And then additional contraception, if BB patient comes, she is allergic to metronidazole, second line treatment, you will offer her clindamycin gel. So if you are giving her clindamycin gel and she's using a condom as a contraceptive method, you'll advise her, to use additional reliable contraception, because it may weaken the strength of the condom. So that will make you a safe doctor. That you have, it's not that you have just, and always remember that it is a holistic approach. Everything you have to take care, like, mm, you know, like our mothers take care of us as a whole, you know about all the aspect, about the studies also, personal aspect, professional aspect, grooming also, mannerism also. Similarly, if a patient has come to you or there is a station for you, you just cannot occupy your brain with bacterial vaginosis. If a bacterial vaginosis station has come, you have to think about all the things which can affect her due to bacterial vaginosis, or if bacterial vaginosis treatment can affect her in any other aspect. So these two things, assure her that it's not an STI. You are a safe doctor, you have assured her, you have reduced her mental health burden. It's not an STI, but if it happens again and again, it put you at risk of STIs. Yeah. So that again makes you a safe doctor. That okay, she has advised also, but offer metronidazole if she doesn't have drug allergy. If she is allergic, offer clindamycin. Clindamycin, are you using condom? You need to ask what contraception you are using. Take another good contraception along with that. Yeah. Pre-pregnancy counseling station comes. Ask about vaccination station. Ask about rubella vaccination in all pre-pregnancy stations. Yeah. Or any infection with the rubella in the past. Are you aware of that? Have you ever got vaccinated for rubella? No? Okay. So did you ever get rubella in the past? Mostly they are having rubella. The ones who are not having, they are being vaccinated. So before pregnancy, they are to be. So, and if you are offering rubella vaccination, tell her not to conceive for 1 more month. Okay. So, like this, whatever you are saying, along with that, there is a safety point. So speak that also, so that the domain will be completely covered. In applied clinical knowledge, you have to recognize any risk management if it is to be done. I'll post the incident reporting, that TOG, risk management TOG, is having a box of incident reporting, that when you have to report the incidents in obstetric scenarios and in gynae scenarios. So if pph it's more than 1.5 liters in your labor ward itself, it is written that 1.7 liters of blood has already been, um, gone, then she has lost. Then after finishing the station about, like, I'll do this, I'll do that, this, that, you will say that, now the blood loss is more, it's major pph, we need to report that in our incident reporting. But if suppose some woman, she has come already collapsed, yeah, then there we are not responsible. Incident reporting is to see what has gone wrong from our part, so that we shall improve that, and we should not repeat it. So there is a confusion to the students always, like if any ectopic pregnancy, ruptured ectopic has come, so do we have to speak like she's collapsed and we have done the laparotomy, do we have to do the this incident reporting? We don't have to, because she has already come like this. It's not from our part. So we need not to involve the incident reporting, because that puts a burden on nhs. And um, apart from that, this is for improving your own things, your nhs, like hospitals, um, negligence should not be there. So this is for that. And duty of condor, one thing to be, you need to pay attention here, because what we do in structural discussions, we say, we'll be open and honest about the things which have happened. Duty of condor include all these 5 points. All 5 points you have to mention, whether you are doing structural discussion, whether you are doing a, patient, like simulated patient task. Okay. If you are going to a patient, like suppose if it is a uterine perforation, you'll be open and honest in telling her that the womb has got this, it got damaged, and they formed a rent when we were putting the um, dilator, that's kind of a, metallic instrument. uh, so what, that's it about the duty of condor? No, you have to tell her that we were doing this. Firstly, we put some medicines to make the neck of the womb soften, um, but then that was still tight and we were not able to pass the required instruments. Then there was, we dilated it with the metal instruments, and while doing that, the womb gave away suddenly, and we realized it. As soon as we realized, we put a camera from the tummy. So, that's the sequence of events you are telling her. So, one thing, be open and honest. You told her that you have done the uterine perforation. Another thing, you have told her that how these things have happened, so that she'll have some peace in her heart. Okay, they deliberately have not done it. They were doing this, and this is a sequence of this. I mean, this is a event that has happened because of this step. So you have to tell her the sequence of events. That's mandatory. Now, then we repaired that. We saw it with the camera from the tummy. There was a rent, big rent, which was bleeding. We opened the tummy from a cut in your lower abdomen, lower tummy, and then we repaired it. And but everything is fine now. Whatever she need to ask, or she need to be angry, just be calm, listen to her, whatever she is saying, and then tell her that, would you like to know? Don't keep on saying I'm sorry, I'm sorry. These are the complications which happens. Okay, so we have already taken the consent about the womb rupture in all the DNC and SNE. So you are going to say this, that one, say sorry, I really apologize for whatever has been happened as a result of this procedure. Would you like to know how it will affect you? So, how it will affect you now? For now, it's like, you need to stay in the hospital for more time than expected. Uh, but we will be there to take care of you, and we will ensure that you recover early. And if she'll say, no, I had to go to my job, and what have you done? You have made my life miserable. Will I be able to conceive or not? What have you done? This, that. Then you patiently, with putting a lot of knowledge in your whatever you're saying, just tell her, I will be discussing with my consultant. He know your case, and we all have operated upon you together, so we can put you in enhanced recovery program, so that your post operative recovery uh, will be more quickly, and you may be able to get discharged early. Will that be fine? So she'll be like, okay. So that you have added one enhanced recovery. So these things, these buzzwords, guidelines, researches, evidence suggest, studies suggest this. These make your words effective, and they have an impact on the patient. The patient knows, if she know this much, she cannot be an unsafe doctor. She know everything. So you also guys know everything. Okay, so you just put your knowledge into your words, and simple words in a layman language. And then how it will affect short term, that you need to stay more. Okay, you can expect these many dressings on your tummy, and we will be removing it, and you can come for stitch removal later on. And then long term, always how it will affect short term and long term in duty of conduct station. If any station comes now in exam, your this portion will need 5 points, and if you will miss any, you will not be given complete marks in duty of conduct. If there are 4 marks, you will be given 2 marks, depending upon you want a big pass or you want a borderline pass. So you have to include all the 5 points. How it will affect in short term, in long term, can it affect my pregnancy? No, it doesn't affect it doesn't cause infertility. You can very well get pregnant, but your care will be in the consultant led unit. It will be considered a high risk pregnancy, because we may need to monitor you, okay, in a normal pitch voice. And like a clinician, you have to explain her the what she can expect in the future. Okay, and follow up, always give her the follow up, because there was a little rent on the ball also, so that has also been repaired by the ball surgeon. uh, I'll be booking your follow up after 4 weeks, okay, or after 2 weeks, after 4 weeks, whatever is the condition of the patient. According to that, after 4 weeks you'll have a follow up with the ball doctor as well after your discharge. Yeah, so with all, not follow up with yourself, and follow up with me also. Okay, if any problem in between, you can anytime see the GP, or you can come directly to the hospital. I'll be giving you a 24 by 7 contact number. Okay, so follow up, if you'll not do to a patient on which you have made a complication, or any complication has happened to that person, you have to ensure a good follow up, that she comes for follow up. Then any investigation, if you have to offer her, like suppose in HMOL, you have to tell her, the beta HCG testing we will be doing again on this week, and for that much time. So that now it makes the duty of candor thing complete. An investigation in any complication, if there is, you will be offering investigation in the end. If there is no investigations to be offered, don't offer anything. Then the column will be blank, and there will be no asterisk point for that. But if any investigation is to be done, that should be written. Okay, that should be told to the patient. So risk management, to identify that, if suppose an undiagnosed breach has come, you will do incident reporting, right? On at term breach, undiagnosed, incident reporting. is to be done. So similarly, other never events, retained swab is a never event, you should know that. So these points, you should know that where you have to do the risk management or incident reporting. Okay, shoulder dystocia structural discussion is there, you'll say that we'll do incident reporting. And applied clinical knowledge, another thing is that you have to involve these, you have to speak these words: audits, protocols. Like if you are giving, if you are doing labor ward, keep on saying that we will be, uh, according to nice guideline, this seems to be a suspicious delay in the first stage of labor. According to NICE guideline, it's the confirmed delay. We will use partogram. According to partogram, the labor will be monitored. So, uh, use protocols, whatever you, according to local protocols, will give antibiotics. So, and I'll do reflective practice. If you have left a swab, I'll do reflective practice. If you have missed any case, I'll do the reflective practice. I'll fill this. I'll put it in my um, e-portfolio that this thing has happened. This incidents I'll put in my e-portfolio. And these words, e-portfolio is kind of a like our logbook, but their e-portfolio is like more than a logbook. They include those cases and all the, it is there on the RCOG site what all they include. Like if any incidence has happened which is to be addressed, then like if they missed pulmonary embolism or there is a retained swab, or any mishap or a near miss, then they add in form R of the e-portfolio. And there are ARCP meetings, annual meetings. So they have to, tell the exam, their ES, the supervisor, examiner supervisor, that this incident has happened. You have to be very honestly telling this incident. So the e-portfolio, if you are using, it shows that you have the knowledge about the portfolio. You have to, you are telling this. Okay. um Audits in shoulder dystocia, you will use, we will conduct audits, um, skill and drill trainings. So these words which are there in the guideline, you will use in your applied clinical knowledge, because audit, skill and drills, protocols, guideline knowledge, reflective practices, root cause analysis, why this thing has happened. Suppose if some smear has misplaced, or you're not finding it, or some information has not been conveyed to patient, which is like cancer information, report has not been conveyed to the patient. So those things, they demand a root cause analysis. So if you speak it in your station, it shows that you have a very safe and sound knowledge about your topic. So I will be doing a root cause analysis of why this thing has happened. Okay. I'll do a reflective practice. I'll put this incident in my e-portfolio. That makes your answer complete. We may conduct an audit if the guidelines are not being followed, or if the incidence is rising, cesarean section incidence is rising, we may need to conduct an audit. So that will depend upon your, because audit stations are coming so frequently in the exam. And you have to know the complete audit definition and the cycle, and you will be using that throughout your whole station. Okay. I mean, what I mean to convey is that don't get scared of any station. Use the cream. These points are the cream of the station which will give you marks. So just be calm. You know everything. Put it in your own language, in your own style, to the patient and convince your patient. Okay. Now, communication with patient and family. This is one of my favorite favorite domain, and very easy to handle domain. Especially, we, whoever like to talk more would love this module, love this domain. Why? Because mm, you just have to interact nicely. Just listen to them, be patient, speak less. People speak too much. Candidates are speaking too much. Too much speaking is dangerous, always, in life also and in exams also. You have to remain silent, like not silent, but kind of, speak when it is required. Take permission from the patient for speaking. Patient don't remember doctor's prescription, they remember their communication. So introduce yourself, very nicely introduce yourself. Tell them that they can also, you introduce yourself and ask them how would they like to be addressed. Don't keep on, don't start by taking their names. They will get offended, they may get offended, and sometimes some role players, they really get offended. And then they will make your station like not easy to do. Okay, so if you want smooth things, then be a, so then you okay. So introduction, you will be telling her what is this your name and age? Yeah, so you have confirmed the name and age. You are a safe doctor, right? You have confirmed the identity. Introduce yourself, that who are you? You are ST5, ST4. Where are you? In which clinic you are? You should have a, so these two three points are for your awareness to the surroundings. Okay, if you are not aware where are you, or if you can just say I'm ST5 in the clinic today, and how would you like me to address you? Ask that. Whatever she says, you can say, okay, you can call me this. Tell her your name, that she can call you by your name. That makes a bonding between you and the patient. Okay, take her idea. What are her concerns? Okay, so may I know what brought you here today? Or is there anything you want to tell me, or is there any specific concerns you are having? That makes them so comfortable. They tell you that what they want, why are they there. It's not that I can see that, all those ratified thing we speak, that I can see that you are here for this. So let's, then you quickly make agenda. All of you don't give time to even answer your patient, or your role player, that she can also reply you something. Even if you tell her, okay, I can see that you are here because you have vomitings from last 3 days. So will that be fine if I ask you a few questions, and then we will do this and we will do this, and then we will make a management plan? Okay, that's not a good idea. To talk like this, always ask one question and then pause and then let her speak, and then answer that. In the beginning, always ask, what are your concerns, please tell me. I can see that GP has sent you here because you had vomitings. Is there any other thing that's bothering you? And anything that you want to add from your side? Mm-hmm. Okay, so let's talk about it in details. Will that be fine for you? You want me to give you any anti-sickness medicine first so that you'll be at ease? I want you to be comfortable first. Okay, right. So, do you have any drug allergies, if I may know? Okay, so I'll ask my nurse to give you a injection first. So, in the beginning only, you have made a very good rapport with the patient. Suppose if you had any vomiting episode or something, and you have reached the hospital and somebody treat you like this, rather than badging you with the information they have, and starting with the station and being in very much hurry to finish the meeting, so that won't make a good impression. And if you do it systematically, believe me, you will be having plenty of time, that you will be left with 1 minute. Okay, so tell her that, ask her concerns and take an idea. If she has any investigations, ask her, does she have any idea about the investigation, or does she have any idea about the situation, or about her condition? She's a cancer patient. If it is a breaking bad news, if it is a infertility station, she's for the investigation discussion. Ask about how much she knows, so that your half job is done. Suppose if you are asking 3 4 minute history and she know it already, and you are asking this and that, and already the documentation, or she says that I know that I have this, doctor has given me this option, I have opted this. Now when you will start again from the scratch, and this happens very frequently in MRCOG part 3 exam, believe me. So what, you are going to open your station by taking knowing her concerns and taking her ideas in the very beginning. Make a very good start, take your 1 or 1.5 minutes, that will be done in 1.5 minutes maximum. Then make a suitable agenda, not that rata rata have fun. Just say that, okay, we will talk about it in details, and however you want to speak it, make your own style, come up with your own style, own words. Don't speak somebody else's word or your mentor's word, that speak this, speak that, don't speak this or that. Just whatever you are feeling like, make an agenda in the way that what are you going to do with her. May I gather some more information from you, and not few, couple of questions, few questions I'll ask, and then we can discuss a management plan. Will that be fine? If she'll say no, it's not fine, you're not going to do that. She'll say no, no, you just tell me my investigation. That means the station is, she's not rude. She wants to know the investigation, because station will not give you marks for that. Okay. So you explain the okay, well, and so will that be fine? Okay, I'm explaining you your investigation. I've confirmed your name, your number, and now we are going to talk in detail about your investigation. Then explain the treatment, and if there is a information gathering domain present, then ask few questions. Okay, ask few questions like, whatever is related to that, like hydrosalpinx, if it is coming in the HSG report, you ask her, okay, so may I know since when you are trying to have babies, how frequent is this, I mean, how frequently are you doing sex, and were there any STI, sexually transmitted infections in the past, was there any operations done on you? Okay, so like that, relevant history, any drug allergy so far? Okay. Any other concern? Family history of concern. Is your partner fit and well? What's the age of your partner? Any other concern? Have you ever, mothered a child, or been, both of you, any of you have any children, have any child in the past? So like this, you have to take the relevant history in the end. Her first, so that she can be at calm, at peace, and you can carry on with your station, and whatever she guides you will be your station. So don't impose your own ideas, previously fed ideas. Just go by the station, wherever it takes you, and believe me, it's going to take you where you are supposed to be. Then autonomy, it's her choice, never yours. But at the same time, you're not going to do everything what she says. If there is a footlink presentation and she says no, no, just I'll go for vaginal birth, this is my second baby, why you want to have a this thing, delivery? Be very stern on that it's not safe for you. We don't advise vaginal delivery. If still she is adamant, it's not like, you have to tell her that it's, baby safety is a concern. We respect your wishes, but I would like you to have a word with my consultant also. I would arrange a quick meeting with my consultant now. Okay, so don't offer something which, if she says fiddling, I want to get a vaginal delivery, I say okay, your wishes are my utmost concern, so okay, I'll explain you how delivery we will conduct. Then you are not a safe doctor if you are offering vaginal birth to a footling. She may have 100 of the things, so you are not going to do that if guideline says that it's not recommended. Okay. Then active listening has a very big role in communication with patient. Non-verbal and verbal. Non-verbal are, in remote exam, in this online exams, you have to just see, just look onto your screen, and nod your head, keep on saying, I mean, just like I am doing that, like, okay, oh, is that so? And I can see you. I understand that how you are feeling. She will say, how can you understand? Did you have any anomalous baby? Did you have any Down syndrome baby that you can understand? So don't use the terms, I mean, the words which are not relating to the station, okay? Just show your empathy in a non-verbal command, and just show it like, okay, I can see that. Yeah, it's a big concern. Yes, I agree with you. That's concerning. Yeah, it's really, yeah, I can see it's putting stress on you. I can see you're stressed. If she's really stressed, if she says, no, no, I don't want this, it's really, I don't like this news. And say, I can see
And
you are
please,
very upset, or I can see
and please
that's,
repeat these things again, please.
pardon me,
Please repeat this.
which one? Active
That I
listening?
can see you. So we cannot say like I understand you have go this.
No,
So we should not
no,
say.
no. See, if she has some condition, okay, like suppose she is having a Down syndrome baby and she's so upset that she started crying in front of you, then you'll not cry with her, okay? And you are not going to say, I can understand you're so upset. Understanding means something which you can relate to. You are having that thing and you are understanding. So it is written in PILs also, and everywhere in the communication with patient, we always, we support them. We don't go with them where they are going or they are taking us. Just be very, very empathetic. Yeah, I can see that. Yeah, it's stressful. Yeah, I can see you're so stressed. Shall I reschedule the meeting, Mrs. Whatever XY? If you wish, we can reschedule it. Do you wish me to call someone? Yeah, it's upsetting news. I can see that. You know, you because um understand, if you say I understand that, then the next question will be why? How can you understand my thing? You cannot understand that. Understanding means you can relate to that. Exact meaning of understanding. You can relate to the thing which another person is having. So saying this, that I understand that, is a lethal thing. They can reply you back, why? How can you understand? And this thing has happened in past exams, one-to-one exams, that people who have given exam, they used to tell us that don't say this word, because then they were like how they become more upset, that you cannot, you don't know what kind of situation it is, how can you understand my problem? So just tell them, yeah, I can see you are stressed. We can offer a counselor for you. At this point, you can bring counselors. Say silent for 10 seconds, break the news, say silent. You can count down to 10 or 12, and then start again. Then you start. Give just 10 seconds, not more than that. And then ask her again, "Mm, would you like me to reschedule the appointment? I can do it for you." Okay. Then she'll say, no, no, carry on, because they also have to pursue with the station. So you say, okay, I can see that it's really stressing, but we have good counselors. They can help you and support you in this situation. You can talk to them your heart out. Do you wish me to put you in touch with the counselor? Then your counselor part has been tick marked. At the same time, you are an empathetic doctor. You know what's their requirement. You have a knowledge, you have a safety point that she may have mental health problem because of stress. So you are offering her a counselor at this time. Okay, don't offer counselor in the opening sentence that we do have counselors. And when there is a scene, or there is a point, you will get to know that you have to offer the counselor. And if there also you forgot to offer the counselor, you offer it in the end, never in the beginning, that things have started and you have offered the counselor. So just wait and just talk about it in between. um, Appear in the station as if naturally you are appearing, okay? like she's the live patient, your patient, and you are doing a private practice, and this patient will give you like so much of money in your private practice. So behave like that, and talk to them very nicely, very empathetically, that like that you will do everything for making her comfortable, right? So that's the active listening. Non-verbal plus verbal. Verbal sentences, if you are using less, it will work. But non-verbal also, you have to, keep on understanding, keep on listening, and let her talk more so that she can vent out. And then you give the knowledge in chunks and involving her completely. So, um, understanding checking frequently is very important. Once you say and any difficult explanation you need not to give, just make it very very simple. Suppose if it is a topic, tell her that yes, you are pregnant, but I don't have a, and if you have to break a news, give warning shots. And when you give warning shot, just break the news. Don't keep on lingering here and there. I don't have a good news for you. Your pregnancy is not a normal one, it's outside the womb. We call it ectopic pregnancy, and here it can't grow. I'm sorry to give you this news. And then be silent. Just dig, 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 1, 2, 3, and silence. Not like this, I don't have a good news for you. And then you will give a suspense, and then you will say one line that pregnancy is outside the womb. And then you will become silent, and then she'll think that we don't know whatever this doctor is going to tell me finally. So just break the news. I don't have a good news. Break the news. Silent. Start. Just go systematically, and believe me, it will not consume your time. Role player will be very comfortable, you will be comfortable, you will not miss the points, you will not jumble with your words, so that if you think your time is going, then you become panicky and then you do blunders. So don't become panic. Uh, just keep on saying the things very systematically. Take the information very systematically. Let her speak. Take the relevant information, like ectopic pregnancy, ask about STIs, any sexually transmitted infections, any surgeries in the past, what about previous pregnancies, what contraception were you using, any single hormone pill you were using, any coil. you know Give her 2 3 names which are related to that, so that your knowledge is also there and you took a targeted history. Okay. And blood transfusion reservation in ectopic are very important. Rh negative or positive, very important in any early pregnancy bleeding. Okay, so these things are very important, and it will be a shared decision. Okay, I mean, ask the patient that, give her knowledge so that she'll take it, she'll think it, and give her time. Okay, you take your time, and we will talk about it again. And don't let her decide alone. You have to give her enough information. Like, I will give you an example of um, which I have in it is a recall, a latest recall, that at 23 weeks the patient says that I want termination for clubfoot, termination of pregnancy. So uh, she was so adamant that most of the people, they agreed to it, and I have used it in my mock test also. I have given this station to the candidates. So many of the students also, they are agreed to it, that okay, MTP is okay to do. You are right at your place that okay, if she is not willing, so you are respecting her wish, autonomy you are following basically. But this is also wrong that you are offering a termination of 23-week pregnancy just for a club foot which is easily repairable or correctable. So enough information is the key to negotiate also. So tell her that first you take enough information, then if you will have it, and you take, we will arrange this for you. We will arrange meeting with fetal medicine specialist. We will arrange meeting with my consultant immediately, and a genetic counselor also. Your scan can be done in 2 3 days, and we can have a needle testing also. An early test can tell us whether your baby has any associated syndrome or not. Though we can have an idea with the ultrasound also. If grossly it's normal, we can put you in touch with genetic counselor. So, would you mind if I may know, did you have any genetic problem history in your family? So that you have taken your relevant information also. And she will be like, okay, is this your first pregnancy? Did you take folic acid in this pregnancy? Okay. So, you know, keep on gathering information in negotiation station. Open, keep your mind open, and they will not penalize you whether you have taken history initially or in the middle or afterwards. Okay, nobody will cut your marks. There is no negative markings. Zero mark is there, but negatives are not there. So that's the benefit. So you take the history. If you have asked about drug allergies anywhere in your station, maybe in the last when you have closed and she is looking at your face, and you say, "Oh, I'm sorry. May I know that? Do you have any drug allergies?" Then also examiner will tick mark your asterisk point. Okay. So, um, so it will be a shared decision. The point is, offer whatever she says, offer to her, but tell her that I am not happy to do this. Okay, I'm not convinced. And why I'm not convinced? Because you are not having enough information. We have to discuss it again with the bone doctor, with the baby doctor, with the fetal medicine specialist, with my consultant, with your partner, with counselor. We need to involve everyone, and then we will give you enough information, written information, web links. Parents who are having babies affected with clubfoot, those parents you need to talk, you can talk with them. Why we want you to give enough information? Because research shows if the parents who take decision of termination uh, without proper information about the condition have high rate of regrets in future. So it's mandatory, it's good for you if you know if you gather all the required things information, so that you I don't want you to have the regret in future. I want the best for you. So what do you think? Okay, so you have to convince your patient that I'm not happy whatever you are thinking. Why I'm not happy? Because guidelines say this, um, research say this, studies say this. um, Back up your dialogues with the protocols, with the numbers, with the datas. That will make an impact on your patient. Okay, and refer whenever required. Refer them to the this MDT. Refer them to the MDT for further opinion. If suppose it is a high risk for this thing, RMI, risk for malignancy index is high in any postmenopausal, offer her CT scan. If CT scan will have, we will be showing the features of cancer, will be uh, referring you to the multidisciplinary team for further plan of management, to decide plan of management. Involve the team, involve the, name the team members. There are Macmillan nurses who will support you at every point of your care, of your treatment. They'll support you emotionally, mentally, physically. They will be doing we will be trying to keep you as comfortable as possible. Okay, so empathy is the main part of the communication domain. Listen to your patient. He is telling you the diagnosis, and that's 100% true for part 3. They just listen to your patient, because they are actually telling you what this station is and where the marks are. Okay, if they want to hear something, they will say yes, okay, go ahead. Don't get offended by their mood. If they are rude to you, the station demands that. Until unless if you think you have not done any blunder and they're still rude to me, why the lady is like this? Change your way quickly, change your, you know the way you are talking to her a bit. Be very very soft, be come to a lower pitch level and talk to her. Explain her the things which are required, and keep on smiling if required. You can smile also with the patient. So in there are specific scenarios like breaking bad news. So here you have to give warning shot 1 and 2 spike protocol you may follow. And warning shot 1 is like, in the beginning you will be asking her, is there anyone with you, or have you come alone? If she asks, why are you asking this? Because I have to give you a lot of information, and if somebody else will also be there. That will be good. And warning shot 2 is just before breaking the news. Warning shot 1 at the beginning of the station, warning shot 2 whenever you are breaking the news. So before breaking the news, tell her that I don't have a good news, break the news, have a pause, and then restart. Okay? Clear explanation is very important. And empathy should be in your voice. Like as if you are giving information to someone who is sitting next to you. So that empathy level should be there in your voice, that I'm sorry to give you such news. Once sorry is, it sound good. Second time sorry is a little annoying. Third time sorry is not acceptable. Don't keep on saying sorry, sorry, sorry in which you are not involved. Just and sharing information with me again and again and again, need not to say. Just say, okay, yeah, thanks for sharing this. So let's come on to the next plan, how we can go about it. And give her options of clear explanation. I hope you understood that if it is a cancer, you're not going to tell her that, your report suggests that there is a papillary adenocarcinoma of the ovary. Do you understand what it is? How will she understand? You have to tell her that it is a cancer in your ovary clearly. Then take a pause. I'm sorry to give you such information. I know it's really difficult to have this. Okay?
Ma'am, I have a query. In
Yeah.
case of history taking, when I told the role player, do you feel down or depressed for last couple of weeks regarding mental health? If the patient
Hmm.
say that I feel worried, I'm worried about my condition. At that moment, should I say that I will connect? I would like, if you want, I can connect the counselor with you at
Mm-hmm.
that time,
Definitely. Definitely. You have to
because
sort it
later I
out.
may forget.
Uh, that's what. If she is a smoker, do counseling there only. That
Yeah,
okay,
yeah.
I can put you into. That's a
In
very
case
good
of
thing.
high BMI that time.
See, high BMI 35, you have to note it. Okay, just note it down. More than more than 25 BMI, you have to note. You can't ignore that. We all think that 25 to 30 is good. It's not good. She's overweight. So you have to address that
Overweight.
also, right? So you cannot
Yeah.
just do the obesity counseling more than 30. We have to tell one word about overweight also. So if she is obese, mostly the stations which are coming nowadays, especially in online exams, they are fussy about their weight. This is what I am observing from, whatever my friends are telling me. And in my own exam, it was like she was very fussy. For others, she didn't say anything to me though, and I didn't know even that there is any fussy station. But she was really creating a lot of problem for everyone in this weight management thing. So this is a very good question. What about the BMI thing? And mental health problem, you have to assess her. Okay, so you feel down or depressed, in couple of weeks, okay, and uninterested in the surroundings, because you have to complete the three only questions. DDU. If anyone is positive, you have to offer her Edinburgh Depression Questionnaire. That's what the guideline says. So you will be saying, okay, so um, that's a concern. Like, is there any particular reason? Do you have enough support? hmm So, did you have any mental health history in the past? Any problem like for which you have visited the doctor, or you have taken any medicine? If she's not having any history, any medicine, Mrs.
Like ma'am, the patient has ectopic, patient already know previous recurrent ectopic this time. So patient is worried about that. I'm feeling worried
Which worry?
and anxious.
For
Like the
what?
patient has recurrent ectopic pregnancy.
Okay, okay, yeah. So
And
in that
and
situation, mm-hmm. Yes. So in that, okay, don't worry about this. We are here to help you in best possible way. I can connect you if you wish. Always. I can do that for you if you wish. It's not that okay, I'll make a referral for counselor. So see the counselor. You cannot say this. Okay, so we are having very good people, you can talk. Now you know the reason, right? You know the reason is
Hmm.
anxiety about recurrent pregnancy loss. So otherwise
Yeah.
she's happy. Okay, apart from that, do you have any other concern which bothers you? No? All right. We do have very good professionals. They talk to you. You can talk to them. You can speak your heart out. They keep your things to them. And they make you feel better by talking to them, and uh, they talk to you in a way that you understand your condition better and you're ready to face your situation. And if anything else is required, if that will also not work, we are there. I'll give you my contact number. Reach out to us. We will be helping you out in this. And we are doing a ultrasound for you, and offering you this urine test. Go for that, and we will discuss the reports. Okay, whatever will happen, just remember one thing: we are there to help you in all possible way. Okay, you're not alone. Reassure, offer a counselor, be with her, and you go ahead quickly. Move
O-
forward. Okay,
Okay. Here,
and then
connect the
BMI.
counselor, and also we will give the proper support.
Yeah, we
Okay.
have to offer support. Yeah, and apart from that, any BMI thing comes. What I did, I will tell you that, and what how you can counsel obesity stations. Just tell them, we have a, if she's too obese or something like that, and if she's overweight also, we have a ratio. We calculate a ratio by taking your weight and height. That's BMI. We call it BMI, and that's in you. The normal range is between 18.5 to 25. In for you it's 28. That's a little higher than a normal, and the WHO categorize this BMI into four categories: overweight, then 1, 2, and 3. Okay, so yours is in the overweight. That's little higher than the normal. You can come back to the normal for coming in the perfect general health. What do you think? We can get it done by modifying a little bit of your diet, joining exercise programs. That's gonna help you. She'll say, no, no, doctor, I've tried a lot. It's not my cup of tea. I can't lose weight. Yeah, I can see that. That's really a big thing. Like, it's a trouble actually. But, studies suggest that if you are in group programs, group exercise programs, they keep your motivation high always in a sustainable manner. So, what do you think? Shall I put you in touch with the group exercise programs, or I can give you the links if you want to see that? Because as you're not able to conceive, so this can also affect the pregnancy rate or infertility. It can be related to this. Studies suggest that, guideline also says that if you reduce a bit of weight, the chances increases for you. So you are not calling her obese also. And if she says, okay, you want to say I'm obese. No, that's, I'm not judging you on however your body type is, but my aim here is to give you full information and keep you updated with that. Yeah. So according to WHO, which is the central body, your weight is in two category. That's quite high, on a higher side. So now how we can reduce this BMI? We cannot increase your height now. So but the weight is the flexible thing which you can reduce. And if you reduce it to some ounces, if you lose, your chances of having a better health will be more. And apart from the infertility, it also causes have a effect on your heart, on your liver, on your also it has bad effect on your ovaries, womb, which later on, and it can cause sugars also in later life. So many problems it causes. So what if we put some efforts, and we get more results. So you are not offending, and you are just, and the category 2 with hyperprolactinemia was my station, and I counseled her like this, and she was the one who was very fussy. That I realized later. I got to know, but this patient I've counseled in the same manner, that we can reduce, if you loses few ounces, the fertility will increase, and also the later on effects. And even if you get pregnant, there can be many things which we need to cover. Then we need to pay attention, we need to deal with. So what if you enter in your pregnancy with the best of your health? So what are your thoughts about it? So they will be convinced. Until unless you do not use your words or sentences properly, they get offended. And if you use your sentences properly, people are with you. Okay, they won't say you anything, they will let you go in the station. Explain them. Once she'll get pregnant, she will be having a high risk pregnancy, and how it affects on, if she, then you ask her, if you have a limited time, ask her, do you wish to know how it will affect your pregnancy also? Then she'll say, no, no, that's fine. Then you go on. That means it doesn't have any marks for you. So you go on.
Hello,
So
ma'am.
most,
In case
yeah,
of weight loss, we connect the patient with the weight management clinic and connect with the support group and some weight
yeah,
losing pills.
yeah, yeah. That you can offer. See, if in morbid obesity, like in my station in hyperprolactinemia, infertility, and she was having 39 BMI. And I told her that though it is there are some surgeries, weight loss surgeries, which are being offered if your BMI is more than 40, but as it is affecting your fertility also, we can still offer it to you at 39 BMI. So I will connect you with the surgeon who do this weight loss surgeries, and also I'll book an appointment with my consultant. Yeah, so we can offer you that. Along with that, I
Ma'am,
can put you in touch with, yeah.
if the patient is young, that then we can try by other measures. Or if older
No other
patient, then
methods.
can offer the biotic.
Yeah, see, if they see guideline says, yeah, in young patient you can still give an option, but the thing is, guideline says that more than 40, comorbidity of a bariatric. If less than, I mean, 35 to 40, but at a higher range like 38, 39, 40, along with that she's having any comorbidity like hypertension, diabetes, now she's having infertility, so you can still consider that. Okay, so you can speak this in your infertility station if the BMI is too high, that there are some weight loss surgeries also. If you'll not get success in losing weight on yourself, we can offer you that as well. So for that, I can put you in touch with the surgeon if you wish to, and with my consultant, I can book an appointment so that we can discuss about your options again. What do you think? Yeah, okay. So be very cool, and don't think so much that you have to, you know don't have to say this word or that word, or you speak whatever is required to convince the patient, but the right knowledge. Okay, and if it is written that with comorbidity she can be offered in type 2 also, so you can offer her. Okay.
Okay, ma'am. Ma'am,
Yeah,
another thing is if its impact on pregnancy, like
yeah,
there is a chance of developing a high blood pressure, so you will be given as aspirin to
yeah,
prevent the hypertension related complication. That time,
yeah,
ma'am, or
yeah,
later, like that there is a chance of birth defect, so you will be give high dose folic acid.
yeah. Yeah, aspirin, you see why I did not included aspirin in patient safety, because though it is written that for the prevention of preeclampsia, it's more so of applied clinical knowledge, that aspirin, if you're giving for preventing preeclampsia, it has evidence that it prevents, and in more than 35 you are giving her how much dose?
Aspirin,
Aspirin? Yeah.
150.
Yes. So that clinical knowledge of obesity guideline if you have, you will get ACK point 1. Applied clinical knowledge 1 point you will get on 150 milligram of aspirin. That all the points you have to keep in your mind. Okay.
Okay, ma'am. And IVF, the BMI should be less than 30, ma'am.
Yeah, no, less than 30 BMI is the best BMI on which IVF is being offered to in NHS. So,
NHS
but it
funded.
is very, yeah, but it is always good if you keep it under 25. Okay, but less than 30 we will be offering you IVF. Okay, in NHS, IVF if you require, it will not be offered at 39 BMI because the chances of failure are too much. It's not that we will not offer you. Then because a high weight there are more chances of miscarriage and more chances of, if we offer you any treatment, more chances of failure are there, and IVF being a complicated procedure, it's tough. So NHS doesn't offer you if you're not in well within your weight limits or BMI limits. So the requirement is less than 30. So we can
Okay,
make
ma'am.
it. We can make it. We can
Ma'am,
make it together.
I
Hmm.
have one more question. In case of maternal medicine, we say that effect on mother, effect on baby, then you will be in a high risk pregnancy in the concerned late care unit, then antepartum care, interpartum care. During when I say the effect on mother, like you may develop blood pressure. In that case, a sprain and clot. So will be your risk assessment will be done. If needed, blood thinner will be given. Effect on fetus, baby may have the birth defect due to this high weight height ratio. So you'll be given high dose folic acid. That time we can say, or during antepartum care, I have to say.
See, you say it anytime. You say whenever you feel like, but you give appropriate information, less information, whatever is required. Don't keep on saying we will do this to you. You will be having this. You are at high risk of having this. You will be having this. Your baby may die inside the womb. No information to
Not
the patient. Okay?
okay. The
Like,
women who have the this condition can develop this,
yes.
so it will be
Yeah.
given to prevent this.
Yes. So you will be saying, a woman who have this high BMI or high weight to height ratio, they are at risk of having developing high blood pressure during pregnancy. So we offer a medicine that's a small tablet, that's baby aspirin. So we offer that to prevent this further complication of having preeclampsia, that's the high blood pressure. Some proteins comes in the urine. Be very clear. Okay, do you with me? So we will start it for you as well, right, to avoid this complication in you. And also we will be monitoring you in a consultant unit. That will be a team will be there to take care of you, right? Some few visits midwife can also do. You can have with your GP where no further examination is required and only blood pressure monitoring is to be done, so that you don't have to come here again and again. And apart from that, it can also be seen that this is related to blood sugars level also raises in the pregnancy. We call this condition gestational diabetes mellitus, GDM. Okay, so we will be offering you a sugar test, special sugar test at 24 to 26 weeks. So what complication can be there, what treatment you will be offering her, where you will be doing her ANC care. Quickly, two, three points to the mom, to the baby, and then come down to and then at 36 weeks, we will be having a joint meeting where we will be assessing you, moving and handling things, and if we need some special instrument for your care, okay, special um, trolleys, that all we will be assessing at our hospital level. And also your plan of delivery will be made. You can very well go for vaginal birth. We don't have any this thing in that, but if there will be any indication, like for you or to the baby, then we may offer you a cesarean section. Okay, the labor may be prolonged. It can be a long labor, and baby as I said, the baby may grow big, baby may take more time to come out, and sometimes, shoulders of the baby may get stuck. So that becomes an emergency. Though we have a team who is trained in dealing with the emergency, but these things may happen, and I will also give you written information about this condition, that how we deal with it. Though it looks scary, it sounds scary, but we can manage it in many cases, but sometimes it's unmanageable. I need to inform you that. And apart from that, you may bleed more. So if I may know, you do you have any blood transfusion reservations? Okay. If she says yes, I have, I won't accept any blood. Okay, I'll note it down, because we may have to sign a different consent form for that, and I may need to attach it in your file. Uh, uh, and may I know if at all you bleed so much that your life is at risk? Well, in that condition also you'll not receive blood because we have to document it beforehand. Okay, and can you receive any other blood products? Okay. So these are the things you take by one. Okay. So stepwise, you have to keep on asking her, keep on documenting, and documentation is the utmost important thing. Close the station with community care with documentation that I will document whatever we have discussed. If you don't document, you are not going to win this station. So, you know, I think if you will include the points, all the safety points, you will communicate well with the patient, and you give her little bit of knowledge, and whatever you are giving her a plan. See, plan is always a plan, a broad plan. It's not, you are digging down inside and continuously speaking and overloading her head that it may burst. So that's not a good idea. Plan will be few lines with what you are going to do, few important things, and what is your plan to deal with that problem. We will keep blood ready. You may go for cesarean we may need to perform a cesarean section. We will keep OT ready once you will go in labor, or once you will reach. Okay. So there will be a team. One-to-one care will be provided to you. So what is your plan for her? You have to tell her only that. After the birth of the baby, what will you say? Just talk to her about breastfeeding and contraception, VTE risk assessment. These three things in post delivery period you cannot miss. Okay. Tell her that we will encourage you to breastfeed your baby. We will give you contraception counseling also to have contraception, what contraception you can use after the delivery to avoid unwanted pregnancy. And we will assess you for the risk of clot formation again after delivery. We'll encourage you to move around and have lots of water. So that's how you end the labor delivery station, the plan of delivery station or high risk station, any maternal medicine station, any pre-pregnancy counseling station. Completely you involve just 1 2 1 2 1 2 1 2 3 1 2 3 important thing, treatment, this and that. Involve the consultant always, how you are going to take care of her. And then what will you do for her labor? What will, if she is epileptic? We will not give you certain pain relief options like pethidine we use for other women. We'll take care that we are not going to use in you. Even if you forget, that's okay, because it may or may not be an hysteric point. If you remember, that's very good that you don't even miss a chance. So, but if you forget, because that's not so important to tell something which is not required now. It's kind of a show of knowledge to the clinical examiner that I'm going out of my way of telling the examiner that I know pethidine is not to be given in epilepsy, right? So that kind of out of the way approach is also like not much required. And closing documentation, if you are not able to, if you any of you is poor in closing the station, close the station in the beginning. When you are making the agenda, tell them that in the end I will write back to your GP. In the end, I will be giving you written information. So, because your points will
Ma'am,
be
in
given.
case of antenatal case, right back to midwife or GP.
See, antenatal care will not come to you. if she is not having any problem. She will come to you for following up with you. So you will write back to GP always. Even if she is in community care, you will write back to GP. Doctor doesn't write back to midwife. Doctor write back to doctor. Okay,
Okay, ma'am.
you are going to write back to GP. You don't have to write back to midwife. GP will arrange the midwife, whatever GP want to arrange with. Okay. If any, suppose
Okay,
if
ma'am.
any that wheelchair patient or any like patient is there who is, you find that she'll not be, it's not good that you ask her to come again and again, so you can offer her a shared care. Okay, midwife will be visiting you. For some visits can be done by midwife, some visits you do with us, so that be regular with the visits, so that it doesn't put pressure on you also, coming here again and again. We'll make it a shared care. What do you think? She'll be very happy that go out of your way in having empathy with the patient. Do whatsoever you can do for the patient. All right.
Okay,
Is
ma'am.
that
Ma'am, that
clear
means
to all?
shared care means patient will come
Shared
to
care means,
hospital and so midwife will go there.
yeah, see, at some visits, they only need to check the blood pressure, fundal height, okay, and need to plot the fundal height on the chart to see the growth of the baby. So that can very well be done at home. So if somebody is not able to move around much, so you can offer that. Okay, would that be fine?
Okay, ma'am.
Is it
Yeah.
understandable? Yeah. Okay, so I have these one-to-one station courses also in my academy. If anybody is interested, can book that and any virtual circuits. If anybody feel that there is a requirement of feedback, we have 7 and 14 station options. So you can book your slots. Thank you and all the very best. And I know you people gonna make it now. Okay, come out with flying colors. And I really wish that all of you pass. Okay, all the best. Thank you for attending the session. I'll put the recording in the group.